Welcome, everybody. Hello. So glad you're all here. You're in the right place if you're looking for the Solo Ager Network presentation, which is navigating the changing healthcare system with our wonderful speaker today, who I'll introduce in a minute. But I just first of all want to say the Solo Ager Planning Committee is hosting this event. So I'm kind of a spokesperson today, but I want to introduce our other wonderful members. Thea Curtin in the back. Hello, Thea. And Carol Keller, right here. Terry Fuller, he's shaking his head no, but yes, he's on the committee, very good contributor. And Suzanne Norton, who is the social worker here at the Jenks. So thank you all for being here. How many of you have been to a Solo Ager event in the past? Wow, a lot of you. Great. So the rest of you all, this is your first time, so welcome. Hope it's, thank you for being here. So let me just I'm going to do a very brief introduction into the Solo Ager Network. How we're defining a Solo Ager is somebody who's 55 and over who does not have a sufficient network of support with family and friends. So that's how we're defining it. This, even though it's the Solo Ager Network that is hosting this event, it is open to everyone. However, the topics and the speakers are really geared towards the unique needs of Solo Agers, which very often are the needs of all older adults. So, welcome. So what is the Solo Ager Network? It's a series of programs that to educate and empower people and encourage you to put together kind of a care plan of like, what are the resources, what are the solutions, what's available out there so that I can put together a plan and resources and know what's available to put together support for myself. What do I want? Regardless if you have anybody to help, who you have to implement it, but you have your needs known so that you're clear about what you want. It's empowering for you. And your wishes are known, you get to have what you want. And what we often hear from all older adults is, I don't want to be a burden to others. That's their primary concern. And our answer to that is, having a plan creates peace of mind for yourself and your loved ones. So that's what we're about today. These are sort of the big, broad categories of what we're calling an aging care plan. And today we will talk about health management. That's the category that we're addressing today. So if you have an issue and you don't know who to call, what to do, something has happened, or you just have questions, your first contacts are certainly, if you've been coming to these events, you have been acquiring speakers on a particular topic that have expertise, you can reach out to one of them. You can reach out to the social worker in the local senior center, community council on aging in the town where you live. Here in Winchester, that's Suzanne Norton. And third, Minuteman Senior Services is a fabulous organization that covers 17 towns in this area. They don't cover all towns, but there's an equivalent. If you don't, when in doubt, call Minuteman, they'll point you to the right equivalent agency. You do have a handout on the Solo Ager Network that has that information on it, okay? Just want you to know. So today we do upcoming programs that are scheduled is on October. We have a primer for older adult-centered care, and that is with a geriatrician, Dr. Wayne Saltzman. I heard him speak last spring, fabulous presenter, really practical information. I immediately said, how do I get in touch with him? And ask him to come to the Jenks, and so he'll be here in October. And then in this is hot off the press. We just organized it last week in December. We have an elder law attorney that's going to be coming to speak specifically about healthcare agents, power of attorneys, trustees, your estate planning for solo agers who really might not have, in particular, what do you do if you don't have those kind of automatic key people in place? So please come to that. Great topic. But please come to both of them. Today's agenda, we're doing the introduction, and then we'll have our speaker speak, and then we're going to have questions at the end. I am going to ask you to hold your questions to the end. A couple reasons. One, not to interrupt the flow of the presentation. Secondly, and I just want to make sure everybody's aware of this, WinCam, yay, is here recording the event so that we can also make this important topic available to, in particular, people who aren't able to make it today, and we're thinking like adult children who have parents or other loved ones in their lives who are facing healthcare challenges, who are working and aren't able to come. And with that, I'm going to introduce Diane Savastano, who is our speaker today. So Diane is the founder and principal of Health Assist, which is a Massachusetts-based company that was founded in 2004. And it specializes in helping clients navigate the complexities of the healthcare system. She began as a registered nurse, providing direct patient care, and her 30-year career includes roles as a hospital, insurance, and employee benefits executive, and as a management consultant. So she's done a lot of different things in the healthcare system. And her experience has taught her to ensure that the healthcare consumer is at the center of the healthcare equation. And with that, I am delighted to hand it over to Diane, which includes handing over the clicker.
Great.
Thank you, Diane.
Thank you so much. Okay. Can everyone hear me okay? Good, good. Well, I am just thrilled to be here. We've been planning this for many months. We delayed it a little bit till the fall. So again, I'm just thrilled to be here. I know a little bit about your community just because my stepdaughter and son-in-law and my 3 perfect grandchildren live here. So I spend quite a bit of time here in Winchester, so I was happy to drive up. In terms of my objective for today, I've been doing this type of work with Health Assist for 20 years, but in healthcare for a bit longer. And so I really want to share some of the experiences that I've had along the way, especially dealing with older adults. I also happen to be the daughter of older adults. So my parents are 89 and 90. I'm an only child, and so I'm it, okay? And so what I hope you walk away from this presentation with are some new tricks of the trade, things to put in your toolbox as you access healthcare or maybe work with someone else who's accessing healthcare. Gotta go this way. Oh, that's me. So in terms of our agenda for today, I want to tell you a little bit about Health Assist's approach to healthcare. Also, we'll discuss the cost of healthcare. I'm sure you've heard a lot about that. And I want to hone in on the 3 important factors that have all influenced healthcare over the last 10 to 15 years. They've really made a difference. We'll then move into healthcare trends, and then we'll move into many of the strategies that I use when managing our clients and or use when managing my parents, and or use when managing my own health care. So that's what I hope you have in your toolbox at the end. I do have a summary, and then I did include some resources in the presentation. My understanding is that the presentation will be distributed to you after today, okay? So let's move on with healthcare costs. The bottom line is they continue to go up. And so all I did with this slide is I'm trying to compare the GDP of healthcare in the United States, which is over 18%, with 2 other wealthy countries, the UK and Canada. And you can see that we here in the United States, 18%, over 18% of our GDP, where it's around 11 to 12 in the other countries. And that translates into spending, $12,500 per year, as opposed to around 5 or 6. So big differences in terms of the cost of healthcare. But what's a little discouraging is that although we spend more, our outcomes don't seem to be as good. And the research on all of this is really compared to 38 economically developed countries. So when I'm making these statements, it's in comparison to those other 38 countries. And so spending is highest, but outcomes not as good. Unfortunately, we have the lowest life expectancy at birth as compared to the other countries. We have the highest death rates for avoidable or treatable conditions, and we also have the highest rate of people with multiple and chronic medical conditions. We have the highest maternal and infant mortality. We have the highest suicide rates. Obesity at twice the rate of other countries, and of course that leads to health problems. We're doing a good job with screening for breast and colorectal cancer, and our flu vaccination rate is high, but unfortunately our COVID-19 vaccination rate is lower than many of the other countries. Now, there are 3 major influences that I just wanted to mention that have certainly influenced healthcare in the last 10 to 15 years. I started Health Assist in 2004, so in 2010 there was the passage of the Affordable Care Act. And I saw distinct differences before and after. Now, everyone with the Affordable Care Act focused on the fact that we were expanding coverage for people, which was incredibly important. However, there were other elements of the Affordable Care Act that I wanted to mention because they have certainly influenced how healthcare delivery has changed over time. So not only did we focus on getting people affordable insurance, still a major component, but we also wanted to improve the quality through innovation. And there were actually Medicare Innovation Centers. There were demonstration projects, they were called, to look at how we might do things differently in order to achieve people being insured, but hopefully bringing the cost down as well. Another major component was a much greater focus on prevention. We in healthcare react to people when they get sick. Well, what is it that we could do to maybe prevent that illness in the first place? That certainly would reduce cost. And then lastly, promoting community and population-based activities. So there's a lot of research that goes on in communities to say what might be influencing the health of this community and what interventions might improve the health of this community. So if you're in a rural community that doesn't have access to good, fresh fruits and vegetables, well, maybe you work with the public, you work with the government, local government, to get a better grocery store in a community that indeed could influence people's health. So we were approaching, after the Affordable Care Act was passed, we were approaching healthcare from many different perspectives in an effort to expand health insurance, but to improve quality and access. Now, of course, another major influencer that we've all experienced was the COVID-19 pandemic, which was declared in March of 2020 and extended through 2023, May of 2023. And this was such an interesting time on so many levels. But as a healthcare professional, if I could step back from the anxiety of it all, it was a very fascinating time to see how healthcare was changing. And so the first thing I wanted to mention is that we really were resilient in many ways. What I watched and read about and encountered was healthcare professionals, and I call this just-in-time learning. In healthcare, when we access care for various conditions, generally the recommendations have been well studied and studied over time. what we were doing with COVID is we were learning on the job. We were learning about, how we were treating people. Should we put them on respirators? Well, maybe that wasn't so good. Maybe we should prone them, which meant turn them upside down on their bellies. And so it was fascinating to see the resiliency of the healthcare system to try to meet the demand, also to learn on the job, and also to the adaptation. We developed a vaccination in record time. And so there were a lot of amazing things going on if we weren't also scared and whatever to kind of look back on and say they were good things. Now, we saw a lot of fallout, however, of course. And so what happened is that, in healthcare, everything is driven by who gets paid what and when. And so most of our focus was on the acute care of people in hospitals who were dying. And so we focused all of our energy on that, but the rest of the healthcare system shut down. And so the other entities that make money by seeing patients, your primary care practices, your specialist practices, we weren't doing elective surgeries, we weren't doing procedures. So you saw a huge, you saw practices go bankrupt. And so what we've seen afterwards is a lot of physicians changing the way that they practice, moving away from your independent practice into practices that might be owned by larger healthcare entities. So a lot of reorganization of the greater workforce and especially the healthcare workforce. We saw finally a widespread adaptation of the use of telehealth. I'd been lobbying this for years. I go to doctor's appointments with my clients. I know what it's like, and I'm sure you do, to get them into Boston, to get them into that huge behemoth of Mass General. And there were so many times, I'd say we could do this over the phone. We could do this, in a Zoom setting. But unfortunately, reimbursement wasn't following. But during COVID, a lot changed, so that telehealth has really expanded. Now, it shouldn't replace, of course, the in-person visit. There's nothing like putting your eyes on a patient, but it is really helpful that we have more advanced means by which we can access our providers via telehealth. Labor force changes really have been difficult because we had people experience, people were already experiencing burnout, and it just was exacerbated. So I can't tell you how many physicians and nurses and all kinds of healthcare professionals that just said, I'm done, I'm moving on to something else, even after years and years of training, which makes me very sad. And then we saw a lot of politicization of public health, leading to, mistrust, which is difficult as a healthcare professional when you're trying to encourage someone to embark on something that's scientifically proven and they're hesitant or mistrustful. It's harder these days. That's all I can say is it's harder. Now, the third piece I wanted to mention is the passage of the Inflation Reduction Act. Now, this just happened in 2022, and there are many different components of it, but I want to hone in on the components that are impacting people who are on Medicare. I help people navigate the healthcare system, but we have another arm of our business. And that other arm, we help people who are newly going on to Medicare. We also help people who want to change their Medicare products that they might have in place right now. We also help people who are purchasing insurance on the open market. So we're coming up to our annual open enrollment season where I say, I barely wash my hair for a few days because we are so busy. We're like accountants during annual open enrollment season. But I wanted to mention things I'm very excited about in terms of the changes in Medicare. So with the passage of the Inflation Reduction Act, they really redesigned the Medicare Part D prescription drug program. Now that program, the legislation for that was passed in 2003, didn't get enacted until 2006. And prior to that, no one had coverage for outpatient prescription drugs. But when they enacted the legislation, there was a lot of politicization, there were compromises that were made, and the program was designed to be incredibly complex, and there were holes in it. You might have heard about the donut hole, okay? And so what the Inflation Reduction Act, the Affordable Care Act improved Medicare in many ways, but this is a further expansion of improvements. And so some things that changed is the redesign of the Part D plan. But in 2000, so this is impacting, it's supposed to save $7.4 billion. It's supposed to impact, about 20 million enrollees. So the first thing that happened, and it started in 2023, was the capping of insulin to $35. Now, one of the things we do for our clients is we do a very thorough analysis of their Medicare Part D prescription drug plans. And we have clients that even that are insured who take medications such that they still spend between $12,000 and $15,000 a year out of pocket due to the way it was designed. Okay, so I wanted to mention that. So we've got the insulin covered. That happened in 2023. We stopped, Medicare didn't pay for all vaccines. They expanded what they paid for, so that occurred in 2023. In 2024, they expanded these extra help programs for those people who had high out-of-pocket costs for prescription drugs. And there were these phases of coverage. You would enter you have to meet your deductible. Then you enter the coverage phase. And then you entered the donut hole. And then you entered catastrophic coverage. And when you entered the donut hole, your cost would go way up. And when you entered catastrophic coverage, again, it could be really high. So this year, in 2024, they actually eliminated out-of-pocket costs once you got into catastrophic coverage. So clients that I used to analyze, and maybe they would spend $10,000, $12,000, $15,000 a year, the most they spent this year was $4,000 out-of-pocket. But the good news is that in 2025, that's going to go down to $2,000. So no one, even if you take really expensive drugs, things like biologics and chemotherapeutic agents and, excuse me, it's going to be limited to $2,000. And there's going to be a program where you can actually, it's called smoothing. You don't have to pay that $2,000 up front. You can pay it out over the year. Don't know how it's all going to be implemented yet. The regs haven't come out yet, and it's happening soon, so we'll see. And then the other thing that is huge is, as a part of this, is that Medicare will be allowed to negotiate drug prices in 2026. And they've already picked the first 10 drugs. And the drugs that they picked are those very expensive drugs, those biologics. Another one, you might be familiar with might be something like Xarelto, people who have to thin their blood. Well, Xarelto right now costs people, the retail cost is about $600 a month. And even with a prescription drug plan, people could still, have to dish out a lot of money. That same drug in other countries costs $50. So we're going to be able to allow negotiations in 2026. So I'm really excited about this. I like being able to tell a good story to my clients. So how has this all played out? So in terms of healthcare trends, what we've seen over the last 10 to 15 years is we've seen a change in our healthcare delivery system. Here in the Boston area, we've got incredible access to care, but we've seen the consolidation and the change. So we've seen the major entities combine and merge. So we've got MGH and Brigham, and we've got, Leahy BI, and Winchester is part of that. So we've seen a lot of reorganization into what's called accountable care organizations. And this impacts how people get paid and how, the systems all flow. Another really positive thing that we saw as a result of the ACA, was more of a focus on primary care. Remember, I talked about prevention. And so there was a restructuring of primary care practices into what's called patient-centered medical homes. And this just spoke to me because when I, went to nursing school all those years ago, we focused a lot on putting the patient at the center. And so this was kind of a move back to that. And so you saw primary care practices expanding to include things like a case manager who could help with coordination of care, a social worker, maybe a nutritionist, and so maybe even a mental health provider, so that primary care could be more efficiently delivered. Because if you want to implement something to help someone control their blood pressure, well, they might need the services of a dietitian in order to do that. So how do you make that more streamlined? The other thing I wanted to mention is this was happening before, but it's called evidence-based standard practice. In healthcare these days, there's tons of algorithms that are based on science. And so what you see is more and more that, if you have a cancer diagnosis, you can literally go to a website with your pathology report. It's not easy to read, let me just say that. But, and there are tons of algorithms based on science, based on input from, specialists from all over the world into what the care delivery model should be from there. Does someone need radiation? Do they need chemotherapy? On and on. So more and more care is being described in terms of the evidence and how the evidence supports the plan of care. The other thing that you may or may not have experienced is that there's much more emphasis on what's called shared decision making. So this is when you and your physician who are trying to decide on a plan of care come together, the evidence-based options are presented, but now you have to superimpose on that what your preferences are. And I like to use an example of a gentleman that I worked with who, he had prostate cancer, and the outcomes for radiation and surgery for him were pretty much the same. But what happened is he had a terrible experience with a major infection following surgery many, many years ago, and his fears of surgery were just off the charts. So this is where when he said, anything I can do to avoid surgery. So here's him saying, these are my preferences based on the evidence-based medicine that you're presenting to me. One of the things that I think impacts all of us is that more and more responsibilities are placed on families and care partners. And I'll talk about what a care partner is a little bit later on. But when I was a nurse in 1980, that's when I started my career a long time ago, I was a surgical nurse pre and post-op. People would come into the hospital to have their gallbladder out and stay for a week. Right? So I had time the night before to prepare, to do the teaching. People who had really complex surgeries, one day one tube would come out. They were with me, for a week or two, and you could really influence things. Everyone almost goes home the same day of surgery these days, and what that means is that we have to support those individuals because sometimes it's really hard for people to go right back home if they don't have a support system. And then more and more care, even just wound care, things like that. We're asking families to do more and more. We're asking them to give IV infusions into a port. It's amazing to me sometimes as a nurse what we're asking families to do. What we've seen as a result of the pandemic, of course, is longer wait times. With the changing demographic of the healthcare industry, there's a real lack of supply in some respects for certain things. And so I'm noticing, I have clients who call me and we want a colonoscopy, and they're saying, we can give you an appointment in 6 months. So that's certainly a struggle. In the insurance market, we're seeing more and more cost be transferred to people who are purchasing insurance products. And we're also seeing an increased use of Medicare Advantage plans. And so the uptake of Medicare Advantage plans has gone from about 30% to almost 50% for Medicare recipients. And a managed care plan or a Medicare Advantage plan is a managed care plan. So it includes, either an HMO or a PPO, so a different delivery system for Medicare services. Now, let's see. Okay, so what I want to do now is kind of switch gears a little bit and talk about some of the tricks of the trade that are basically very simple and very common sense. And this is what we use when we manage our clients. This is what I use to manage my mom. So I'm going to walk you through a few of these. So despite the fact that we've had huge technological advances, and we all have electronic medical records, which I have a slide about in a second, I highly recommend that everyone have their own personal healthcare file, and I still use paper for this. And in my little personal healthcare file, I have a list of, I have like an Excel spreadsheet with a list of my medical conditions, hospitalizations and surgeries. How often do we go to a new provider and you still, despite electronic medical records, you have to fill out all of this paperwork? Well, now you've got everything in kind of one place, right? In addition, a list of your medications is critical. Not only the drug, but the dosage, how often you take it, who prescribed it, and what it's for. Can't tell you how often when I go in and do an evaluation with a new client that said, oh, that was prescribed for me all those years ago. I can't remember what that's for. Oh, yeah, that doctor prescribed. I haven't seen that doctor in forever, right? So it's really good when you put it all in one place. Again, I use an Excel spreadsheet for this. Your healthcare team, who is your healthcare team? You know, one of the things about healthcare in the United States is it's very segmented and siloed, right? So we have our primary care physician, and I'll elaborate on that in a second, but we also often see multiple specialists and access care from multiple entities, and they might not be in the same system, and that makes a big difference. And what's your preferred hospital? Good to articulate it. What's your preferred, and let me give you an example. I have a client who has, and I use her as an example all the time. She's been with me for 15 years. She doesn't care if I talk about her. But anyway, she has Parkinson's disease, and she has stimulators in her brain. And she's got 2 pacemaker batteries here. And so if she's ever hospitalized, even though Mass General is closest to her, she gets all of her care and her neurology care at Boston Medical Center. Now, I'm sure Mass General could deal with her stimulators, but they know her at Boston Medical Center, so her preferred hospital, if she has to go to an ER, is Boston Medical Center. And your preferred pharmacy, and who's your emergency contact? Now, this gets interesting because your emergency contact might not be the same person as your care partner, and might not be the same person as your healthcare proxy. So for my client, Susan, I'm her emergency contact. However, her cousin is her healthcare proxy. I'm the person they contact first if anything happens, and I communicate with her cousin. And then, in the event that healthcare decisions need to be made, I relay information and he makes the decision. So you'll see when I go further on why I'm making these distinctions. Now, I mentioned patient portals, and hopefully all of you have access to your patient portals, because they have really revolutionized me trying to empower my clients to take greater control of their health care, because information is accessible. So if you're in the Mass General system, you might be on Patient Gateway. If you are in the BI system, it might be My BI Leahy Health. Patient site is still the old-fashioned one at the downtown BI Deaconess Hospital. My chart is at Boston Medical Center and in many other entities. So I encourage you to enroll in one of these portals, because you can do a lot of things on the portal. And you can communicate with your providers, you can provide information to them, you can even make appointments and cancel appointments, you can look at all of your test results, which I think is really important. And you know what piece I just love, and it took a long time to get there with these, is that when you go to your doctor, your doctor usually writes a note, they dictate a note after you leave, and you've maybe discussed a plan of care. But now you have access to the actual note that your doctor wrote. And I find discrepancies when I read those notes, and it's really sometimes affirming afterwards what was the plan of care. And so it's very helpful that you can read those notes. So anyway, patient portals, I love them. Now, they don't talk to each other unless you make them talk to each other. So I have 15 different portals for my parents, because you have doctors' offices who have portals. They live in Florida part-time. They get access to the Boston area. They get access in Rhode Island, where they live in the summer. I've got 15 different portals for them. Now, some of them I can make talk to each other. You have to go on the settings to do that, but they don't talk to each other. So I'm going to my primary care physician tomorrow, and I saw a doctor down in Rhode Island, which is where I live, that is not in the system, has own system in their practice. So I'm bringing the note tomorrow. I mean, talk about old-fashioned. I'm bringing the note so that she can read it. So understanding your health insurance coverage. Now, in my little ideal world, when I first was educated as a nurse and we had a patient-centered model, we thought about the patient at the center, and then we thought of what are all the influencers on the patient. So we have the physician, the primary care physician. We had, I'm thinking of my little circle I used to have, and we had, specialists in the hospital, and the employer, and the insurer. The bottom line is in our healthcare system, unfortunately, your insurance coverage often drives accessing care, payment of care, and so you truly have to understand your insurance coverage and how it works. If you're on Medicare, do you have traditional Medicare with maybe a Medicare supplement plan? That works very differently than if you're on Medicare with a Medicare Advantage plan. In employer-sponsored coverage or open market coverage, do you have a PPO? Do you have a PPO Select? What the heck is that? Do you have an HMO? And the reason it's important is because there's different rules and regulations you have to follow in order to have insurance coverage. And if you don't, you're not going to have coverage. And so it is when you sign up for any kind of health insurance, there is something called an evidence of coverage document, which is a 150-page contract between you and your insurer. That's where all the details are. You get a summary of benefits, which tells you some stuff, but the devil is in the details, especially if you're running into a problem. And so you need to understand, do you have a deductible? That's often what you have to pay before the plan kicks in. Do you have an out-of-pocket maximum? If you dished out that amount of money, after that, the plan kicks in at 100%. It's important to know. Does your plan require a referral? In an HMO, you have to have a referral to go to a specialist, and if you don't have one, no payment for that service. Do you have a network within which you need to operate in order to have coverage? In a PPO, if you stay in network, you have a greater coverage than if you go out of network. But you still have coverage if you go out of network. HMO, you don't. So there are all these different nuances. What requires prior authorization? What requires notification requirements and who notifies? So these are all the rules of the road under your insurance plan that it's really important for you to understand. Now, I'm all about relationships, right? Always have been my whole life. And in healthcare, I really like to emphasize that relationships are so important. So I focused here first on the relationship with your primary care physician. So it's not only the primary care physician, but it might be many other members of the practice. My primary care physician's medical assistant called me yesterday to do some pre-screening before tomorrow's appointment, so I know who she is. The receptionist, they've had the same receptionist for years, There might be a nurse practitioner or a physician's assistant in the practice that you might interact with at certain times. So important to have a relationship with them and to know about them. If your physician is out, you might have other physicians in the practice that you might interact with. So important that you do your homework about your physician practice. Now, I can say that, when clients call me, they're often frustrated, and they might be frustrated by a host of different things. But one of the common frustrations I hear is people say, I need to switch physicians. And when I ask why, they'll say, my physician doesn't communicate with me. Well, these days, switching physicians is not so easy. So one of the things we focus on is, well, how are you, as a healthcare consumer, going to improve your relationship with your physician? And so we actually put it right on the agenda where you can provide feedback to your physician to say, we're not communicating very well and it's frustrating to me. How can we do this differently? The practice manager, if you run into any issues with the practice or billing, a practice manager is a very important person. And then all the same people may be in your specialist's office. My client, Susan, we see her neurologist more often than we see her primary care physician. So we know everybody in that practice because we go very regularly, every 2 to 3 months. Now, this is what I mentioned, an agenda. So, I went to business school after I went to nursing school. And I often, I'm critical of healthcare entities and say if they only operated like real businesses do. Now, one of the pieces of that I take to my work is that I think we should all walk into our doctor's appointment with a written agenda in front of us. I've got my agenda for tomorrow. And that written agenda gives you a lot of control. When you walk into a doctor's office, you often feel like they're up here and you're down here. Well, how do we level that a little bit? And one means by which we can do that is to walk in with a written agenda. And so your written agenda is something you prepare in advance for your meeting. It's your meeting. Remember that. And I always walk in with a paper copy, and I bring another copy, and I say something like, I took some time to prepare for my appointment today. here's my agenda. It helps me so I don't forget anything that I want to talk over with you, and also because I need to take notes about our discussion. And oftentimes I'll even ask the medical assistant to put it on the front of the chart before the doctor comes in. Sometimes I'll send it via the patient portals in advance. But you're demonstrating you prepared, you did your work, and again, this is a mutual conversation. This is just a sample. Often I have at the top the objective. So my objective tomorrow is to go over my preventive care, go over my medications, tell my doctor about some other care I received from other entities, discuss a test result I'm a little unclear about. So those are all my agenda items. But you also, what's so important is that your job is to relay what's going on with you. So you should be prepared with your observations about you, yourself, your body, how you feel. You're gathering data all the time. And if you do have data, which maybe you have gathered, like blood pressure data or blood sugar data, bring that data with you to discuss with your doctor. Go over recent blood work. Go over your medications, any potential side effects, what are the next steps? So this is kind of a classic agenda. And then what's the plan of care? When you leave your doctor's appointment, there's usually a plan. Sometimes it's just come back next year. Maybe it's now you're going to have your vaccinations now, right? Your COVID vaccination, your flu vaccination. And oh, by the way, you're going to have a colonoscopy in 2025, and you need to have your mammogram, and on and on. So what's the plan of care? Any questions? And then you can kind of summarize. So in today's visit, this is what we talked about. This is what we're doing next. So an agenda is a very powerful tool. I wouldn't come here today without an agenda. I think planning is just critical. Now, care partner. And I know many of you are solo agers. So my premise is that even those of us who are very skilled at all of this, it's really important for us to have a care partner if we can. Sometimes it's a family member, sometimes it's a friend. Maybe one solo ager could be a care partner for another solo ager. And the reason I emphasize this is studies have shown that when we go to our doctor's appointments, we remember 25 to 30% of what happened. And if we're discussing a difficult diagnosis, it's more like 7 to 10%. So your care partner is someone who can help you prepare before you go. This is what I do professionally with my clients, right? We prepare an agenda. It allows you to be the active listener because someone else is sitting there taking notes. You're not trying to listen, take notes all at the same time. Someone else is doing that for you. You could even ask to record. Many physicians are not uncomfortable with you recording your interactions with them, and that's another means by which you can review what went on. You can gain clarification. So what I do with my clients, I'm watching my client, and I position my client to facilitate communication, right? So when we walk into these meetings, I'm putting my chair over here, and I know where the doctor's going to sit, and I make sure that Susan is directly in the line of the site of the doctor, so that they talk to them, because sometimes they turn and talk to me, and I don't want them to talk to me. I want them to talk to my client. So what I do when they look at me is I just look away. And so it facilitates communication, okay? But what I do sometimes is I'm watching my client's face, and I'll say to the doctor, now, you think we in healthcare, we use all this jargon. So I'll listen, and I'll say, Dr. So-and-so, would you mind describing what an MRI is and what it's going to be like to go through one, and what's the purpose of this MRI? What information is it going to give you afterwards about the plan of care? Oh, yeah, well, let me review that. So sometimes I'm kind of there to kind of just promote clarification. I'm also there to ask questions. Now, of course, I'm listening with a clinical ear, but care partners can listen really astutely and ask good questions. I like to use the example. I had an eye issue one day. I had a severely scratched cornea, and I was in tremendous pain. And my husband came with me to the doctor's, and the doctor told me the instructions afterwards about the eye drops. And I said, okay. And then I said, could you repeat that? And he did. And I still didn't get it because I was in pain. And then I said, could you repeat it again? He did 3 times. I still didn't get it, but I was embarrassed. But I knew my husband got it, right? So he had the plan of care. And so it's just so helpful to have someone with you if you can. You can hold someone accountable to the plan. So, with Susan, sometimes she's reluctant. Sometimes, the doctor ordered a new medication, and I don't know if I want to take it. So you can kind of be that person to say, well, that was the plan of care. Are you taking that new medication? So just hold someone accountable to the plan of care. And then you can be their crisis coordinator. So again, I'm Susan's crisis coordinator. People call me. I'm my parents' crisis coordinator. I'm my husband's crisis coordinator if he needs it. But you can kind of go into action if, God forbid, something happens. Just checking the time. We're good. Now, a HIPAA release form. So, you go to the doctor's office and you have to sign all these releases and whatever. But if someone else wants to access your healthcare information and or maybe speak on your behalf, well, you have to have a HIPAA release form in place. So I have one of these with all of my clients and all of their doctors and with my parents. And what this does is this does not position me to be their actual healthcare proxy. It gives me permission to speak to the healthcare entities about Susan. I'll use Susan as an example. And it gives the healthcare entities permission to speak to me. So having a HIPAA release form for your care partner or the person who might be your crisis coordinator can be instrumental at them being able to do what you want them to do. That's what I needed. I needed my husband to be there, to be, asking questions, to be listening. So a HIPAA release form is critical. We think about this for older people, but, my grandson and granddaughter, the oldest perfect ones, my grandson just went off to a second year of college, and my granddaughter, her first year of college, and I made sure to say to my stepdaughter, make sure you have a HIPAA release form. They're over 18. The student health centers don't need to talk to you. So if something happens with them, you really need one of these forms. So I wanted to talk about a grab-and-go kit. And again, I'm always thinking about emergency situations for people who not only live alone, but, for all of us. And so a grab-and-go kit is something we used to devise for our clients many years ago. But then during COVID, oh my God, did we make sure that every single one of our clients had their grab-and-go kit in place. Again, very low tech. I have a plastic sleeve in everyone's home, and in that sleeve are some of the tools that we talked about earlier. So a face sheet, just name, address, phone number, and the date of birth and allergies, the emergency contact, right on the front page there. So Susan says you contact Diane Zavastano on this number. If you can't reach her, you call this number, on and on. The signed HIPAA release forms, because the thought is you grab the kit and with the emergency personnel and it goes with you to the hospital, okay? What you should know about me. So Susan's grab-and-go kit says, I have Parkinson's disease, I have stimulators in my brain, you're not allowed to do an MRI on me, I have batteries in my chest, I need to take medication every 1.5 to 2 hours in the course of a day. Now, that's enough, because what happens is once I get notified, I'm calling the emergency room right away to say, I am Susan's, care partner. I introduce myself as a private case manager. I have a HIPAA release form. I'm going to fax that to you right away. I'm going to try to get to the hospital, but in the meantime, let me tell you about her. So, it's just important pieces of information. I had one client, she had severe arthritis in her shoulders, so severe. And she also had Parkinson's disease. We weren't going to operate on her. Everyone tries to move a patient underneath their armpits. It would just cause tremendous pain for her. So something like that, you would relay. Other clients, Mrs. So-and-so is severely hard of hearing. She does not have cognitive decline. She's, hard of hearing. Please speak clearly to her. A copy of your medication, the medical conditions that I mentioned earlier, the medications, a copy of the front and back of your insurance cards, the healthcare proxy if you have it, if you have the healthcare advance directive, if you have any, advance forms that you've signed, MOLST form, POLST form, DNR forms, and maybe even a copy of your power of attorney. Power of attorney is someone who can make financially related decisions for you in the event you can't make them for yourself, where the healthcare proxy, they can make medical decisions if you can't make them for yourself, okay? Most imposed, you might, these usually get initiated with your, oh, I'm supposed to wait for questions so that it gets, is that okay? So let me just relay. So you asked the question, what's a most imposed form? So Massachusetts orders for life-sustaining treatment. This is a form that often gets initiated in your doctor's office, and it's basically another version of a living will. What are your wishes? Okay? Most. Massachusetts orders for life-sustaining treatment. Okay? Now, if you do have to go to the hospital, which I hope you never do, you generally may enter via the emergency room. You may be admitted. And I just wanted to point out that plans for your discharge are happening upon admission. The other frustrated phone calls we get from client families all the time is mom or dad was admitted to the hospital, or brother or sister. They're telling me they've got to leave tomorrow, the insurance won't cover anymore, they've got to go to a skilled nursing facility, I have no idea what that is. Recognize so that you're not caught unprepared, that plans for discharge are happening upon admission. Now, who the heck do you talk to when you're in the hospital, you know? So, and so I just list where I start. If my clients are admitted, I often call the nurse on the unit first and introduce myself. You can do that as well. You know, I'm so-and-so's care partner, or I'm so-and-so's whatever. I have permission to speak to you. How is my loved one or my friend or whatever doing? But then you want to try to get to the physicians. But these days, it's confusing. So in many hospitals, recognize that your primary care physician basically has nothing to do with your hospitalization. They're kind of out of the picture. So most hospitals hire hospitalists, who are physicians who are hired by the hospital to specifically care for those people who are inpatient. So there might be a hospitalist who is in charge of your care. If you're in a teaching environment, you might be assigned to an attending. So let's say you come in with a cardiac event, you might have a fully trained, employed, practicing cardiologist who's the attending, but you almost never see the attending. Who you see is you see the intern, or you see the resident, or you see the chief resident. You might see a physician assistant who's on the team. So one of the things I recommend is that anybody walks in your room, anybody, and they don't introduce themselves and they don't tell you your role, just say, please tell me who you are and what your role is. Just something as simple, oh yeah, I'm Dr. So-and-so, or I'm here to evaluate your blood work for today, or whatever. Don't be hesitant to ask such questions. Lots of times there's boards now, where your primary care nurse is listed, the hospitalist might be listed, but there's tons of people coming in and out, and it's very confusing. And then, very important person is the case manager or discharge planner. That person is assigned to you upon admission, and it's that person's job to coordinate your discharge. Now, these people are very busy. Sometimes they don't introduce themselves right away, but I find them right away because you want to start planning for that discharge immediately. Now, transitions in care. Once you're admitted to a hospital, here's what generally happens. I've had hundreds of clients over the years. So sometimes you go home with no services. You're fine. This was a isolated event or whatever, and, take it easy, that kind of thing. But a lot of times, you might go home with what we call home care services. Now, I'm referencing services that are paid for by insurance. You might remember them as the old visiting nurse services, right? So these services include a nurse, one or all of these, a nurse, physical therapist, occupational therapist, and sometimes a speech therapist will come from, again, this is if you need assistance at home to continue your rehab at home, but it's paid for by insurance because you meet the criteria to receive this care. One of the criteria is that you're homebound. That's why they're coming to you. Next is you might go to an acute rehab facility. So people who suffer maybe major traumas, they need extensive rehab. They still need a lot of medical oversight, but they don't need to be in an acute care hospital, so they might go to Spalding in Charlestown. That's an example of an acute care rehab facility. But let's say they don't meet the criteria for that, but they still need medical oversight and they need rehabilitation, PT, OT, speech. They might go to a skilled nursing facility for short-term rehab. Again, this is paid for by health insurance as long as you meet the criteria for that level of care. Or, someone might be discharged to a long-term care environment because they can't go home. They're not a viable candidate for rehab, so they might go to long-term care. And there's a lot in between all of this. Now, I was asked the question about an ombudsman, for you solo agers, what's the role of an ombudsman? And if you are alone in a hospital setting, is this a person you might reach out to assist you? Let me just say that an ombudsman's role was really designed to problem solve, not to coordinate care. So, that being said, this person, you could certainly call them, their job, they usually sit in risk management, meaning they want to avoid lawsuits. So if someone calls, and I've used ombudsmans, they've been very helpful when I had really difficult situations in a hospital, a lot of contentious conversations, a lot of confusion. So they listen to the concerns you might have, and they may work with the individuals and families and facilitate communication among all of the major players to hopefully resolve issues. But when it comes to coordination of care, where am I going to go after I leave here? Can I go home? That's your case manager. And then you've got ombudsmen also in long-term care environments that fulfill a similar role. So I just wanted to mention that. An ombudsman works for the hospital, and so if you're having any issues or problems, again, you can ask to see the ombudsman, and they'll come up and see you. Again, I found them, I had one case, it was so confusing, and this person pulled together, I had the neurologist, the neurosurgeon, the psychiatrist, the GI doctor, because this woman, all in the same room. Like, it was an amazing meeting, and she pulled it all together because we needed to all be in the same room to decide what was going to happen next with this particular patient. Now, I wanted to just bring up end-of-life planning because I think we should all do end-of-life planning, and I know you probably have done some presentations. I'm so excited you're having Dr. Saltzman come. I've known him for years. He's wonderful. But end-of-life planning is really important, and you kind of start out often just making sure you have your documents in place. I mentioned that HIPAA release form. That's very helpful, but you also want your healthcare proxy. That is someone who would make decisions for you. Again, for Susan, it's her cousin who lives in Colorado. So if she needs care, I would be managing her care while she's here, communicating with him. But if a decision needs to be made, he's the one who had the conversation with her regarding her living will or that most form. And so he's the one that would make the decision, the ultimate decision, not me. That's not my role. The durable power of attorney, and this comes into play with some of my complex clients. We have to spend money when they're leaving the hospital. Sometimes we're bringing in services from home, sometimes they have to pay privately for certain things, and we need to spend money. So if they can't make the decision, who's the durable power of attorney, then can make some decisions about spending money. The living will, again, outlines your wishes as the most form does. And one of the things I tell people about the most form is when you can always change it. And I'm going to give you an example in a second. You want to have conversations. Great to have a healthcare proxy. Not great if you don't tell them what you want, because now they're in the position of having to make a decision without knowing your wishes. And of course, a will is about your possessions. So I just wanted to mention this. People think of end of life. I mean, I've been doing end of life care since 1980. And I have to say it's a very special, intimate time to be involved with families. It's quite beautiful sometimes. But there's a lot of decision making that happens way before that end of life decision. So, we have clients who might have a status where they don't want to be resuscitated. They don't want their heart resuscitated. You have to make decisions about whether or not you want to be intubated. That's a tube that goes down your throat, and you're placed on a ventilator, a respirator. Maybe you don't want that. So maybe your status is DNR, DNI. We have clients, may reach the end, they're not dying, but they know they never want to go back to the hospital because it causes them suffering. They don't want to be poked, prodded anymore, and so we have to do things to make them a DNH, do not hospitalize. There's DNH, do not resuscitate, but hospitalize. That's a status as well. Do not resuscitate, do not intubate, do not hospitalize, another status I've encountered. Do people want hospice care at home? That's how hospice was defined, as care in your home that wraps around the care a family member gives. That's not possible for a lot of people. So maybe you want to consider a hospice inpatient facility. So there's a lot of what I call iterative decision making that occurs at end of life that happens way before someone really passes. So, I deal with many people who have cognitive decline at various stages of cognitive decline, and there's a lot of confusion about it. So I like to just go over a few major points about experiencing cognitive decline yourself or experiencing it with people that you care about. And so we've got, when we talk about cognitive impairment versus dementia, I'll get to dementia in a second, you've got 7 areas that you're looking at. Some are receptive and some are expressive. So is someone having an issue with language, that's expressive. Is someone having an issue with memory, that's receptive. Now, I think it's really important if you're noticing a change in an individual, no matter who it is, if someone you care about, if you're noticing behavior changes, I think it's important to speak up and to act. Acting sooner rather than later is very important. So things you might notice, someone doesn't show up for an appointment that you might have had together or a social event, or you see some personality changes, or maybe they've gotten lost, or maybe they can't find things, or maybe they're becoming a little paranoid, thinking someone's stealing from them, or that it's taken them a long time to do things like dress and that kind of thing. Well, that might be indication that some cognitive decline is occurring. So, now, you can have something called mild cognitive impairment, which is kind of a go-between between normal cognition and dementia. Okay, and this is a brain disorder. You might have some trouble with memory and thinking, and you might forget a little more often than not, but it's nothing major. But dementia, what I like to mention is when people experience cognitive decline or have loved ones who are experiencing it, they automatically go, oh, mom or dad has, Alzheimer's. Well, that is so not true. There's so much you have to go through before you get to that place, right? Or the thing that drives me crazy more than anything, I hear somebody say, oh, mom or dad is losing it. Oh my God, I lose it. And I hate that expression because there could be diagnosable and treatable reasons. So don't just say it's normal aging. Not everyone who ages experiences cognitive decline. I feel very protective of the older adults in my life, not only in my life, but in my clients, because I think assessments are made too quickly. So dementia is an ongoing decline in cognition involving these 3 domains: learning and memory, executive function, which is organizational skills, and social cognition. But dementia is a global term. The most common neurodegenerative diseases that fall under the global term of dementia, one is Alzheimer's disease. That's the most prevalent. But there are others. There is dementia with Lewy bodies. There is frontotemporal, Wernicke-Korsakoff for people who have drinking histories, Parkinson's disease dementia, and vascular dementia. And the reason it's important is because they present differently, and they're evaluated differently, and they're treated differently. So it's really important to know what you're dealing with if indeed you do have someone with dementia. And so this is what happens. People will say, oh, I'm concerned about so-and-so. Here is where I think you should start, and I think you need to get started. So it's important to have a conversation with a person to say, I'm noticing some things that are of concern to me. I really think you should see your primary care physician and start there and just see if there's anything going on, because you know what? Whatever might be going on could potentially be reversible, right? It could be something that's treatable. So you start with your primary care physician who does a history and an examination, and then there are in-office objective and quantifiable cognitive tests that can give your primary care physician an indication as to whether or not any cognitive decline might be present. But your primary care physician also checks for other conditions. Does this person have medication interactions? I have clients who take upwards of 20 medications. The chance of an interaction is like 100%. Sleep patterns, sleep apnea. That can certainly cause changes in cognition. What's their alcohol history? Changes in cognition. Any infection, you do a urinalysis, you do blood tests. Are there any other metabolic conditions such as vitamin deficiencies? And then you might do a brain CT or an MRI. And then often from there, if indeed a cognitive change is indicated based on the in-office testing, and you've ruled out other things, well, then you may be referred for more expensive testing and evaluation. And generally, you're referred to a neurologist, and then you're referred to a neuropsychologist for neuropsychological testing, which is about a 3-hour sort of testing experience where you're looking at all the different areas of the brain to help you to get to a diagnosis so you know what to do next. Again, it could be metabolic conditions. Vitamin B12 deficiencies, vitamin D deficiencies can make a difference. It could be normal aging. It could be mild cognitive impairment, or it could be any of those ones that I mentioned. And again, treatment options are specific to the diagnosis. So when you're dealing with anyone with cognitive decline, and I deal with this all the time, you have to do a lot of goal setting and planning. Planning is key. And again, lots of iterative decision making. Because the unfortunate thing is once someone is in that category of having, let's say, some form of dementia, they're not really going to get better. You might be able to put off the decline with certain interventions, but we don't have cures yet. So you know decline is inevitable. So how do you plan for that? So you have to do some creative decision making surrounding every aspect, even evaluation. You know, I had a client, doctor wanted to do a lumbar puncture to define whether or not this woman truly had Alzheimer's disease. I didn't think she could go through that. So she met the criteria in all other ways, but without looking at her cerebrospinal fluid, we didn't know, but we decided not to do it because it was just more than she could endure. So there are decision making all along the way. For management of symptoms, for treatment, for assistance when needed, again, for transitions, for alternative living environments. So, in summary, I just wanted to say that, our healthcare system is continuously evolving. We as consumers truly need to take responsibility for our own health care. And we often help others with taking responsibility for theirs if we can. Your job is to share your observations and share data with your physicians. You know, I have clients who they go in they've already diagnosed themselves. And I'm like, it's not your job. Your job is to go in with the data, relay things as well as you possibly can, and let the physician do their job. You want to maximize relationships, especially with your primary care physician. They can be instrumental, and that's a long-term relationship. I'm so afraid my primary care physician is going to retire, you know. We've been together for like 25 years, but I'm aging, she's aging, it's going to happen, right? Iterative decision-making is to be expected along the continuum. A decision you make today might be different years from now. And again, preparing and planning is absolutely key. And I just wanted to say that in here, I included a lot of links to a lot of the things that I talked about. I write a monthly newsletter. I think I'm on issue 123. I've been writing them for a long time. So I write about a lot of examples with my clients and a lot of the things we talked about. So I put that there. But there's a whole host of these two physicians at the bottom are from Boston. One of them is written about how physicians think. Excellent. Atul Gawande has written about end of life, and he's done a lot of work on process improvement, really fascinating people. Again, this is about how healthcare has changed, and there's a lot of resources here for people with cognitive decline, some information about end of life information. Yeah, and we do have, you have this as a handout. So you're going to take this, everything that's in the presentation is also on this handout that you're going to be able, you have it already on your chairs. Okay, great. All right, and then at the end of the presentation, which I do hope that you print out the presentation because we didn't have time to go over this, I just included, again, a lot of tricks of the trade and tips for managing people with cognitive decline. So I just wanted to mention that. And that's it.